अभी 6:39 हो रहे हैं एंड मैं 2 घंटे के लिए पढ़ाई करने वाली हूँ रेगुलर। चेक कर लेती हूँ मैं सही दिख रही हूँ क्या। ऐसे तो मैं पढ़ाई करती ही नहीं हूँ, तो मैंने सोचा कि क्यों ना लाइव जाके पढ़ाई करूँ, एटलीस्ट मैं कुछ तो डिसिप्लिन होके पढ़ पाऊँगी। मेरे ना 1 महीने बाद एग्ज़ाम्स आ रहे हैं, ठीक है, और मैंने कुछ भी पढ़ाई नहीं करी है। कहाँ रखूँ? कहाँ रखूँ? यहाँ रख देती हूँ। नहीं, सही है। ये भी सही नहीं है। चलो, पहले मैं टाइमर सेट कर लेती हूँ। मुझे 2 घंटे पढ़ाई करनी है। टाइमर 2 घंटे का यहाँ से लगाते हैं ना, 2 आवर स्टार्ट।
Hi everyone, I'm Dr. Rohan Khandelwal, and in this module we'll be talking about esophagus part 1. Now GIT is super important from your exam point of view, be it any exam. Now it has become the most important and the most frequently asked section. So let's now start with the GIT modules, and in the last few years GIT has become the most important topic from which questions are being asked not only in the college exams but also in the entrance exams. So while watching the GIT lectures, please keep all your senses open, keep your eyes and ears open so that you can get all the relevant information which would be required for you to solve questions. In esophagus, let's first start with the surgical anatomy of esophagus. Now you know that esophagus is a muscular tube and esophagus starts at the junction of, at the level of C6. So C6 is the pharyngo-esophageal junction. This is the pharyngo-esophageal junction where the esophagus starts. And you need to know that this pharyngo-esophageal junction is the narrowest portion of GIT. This is the narrowest portion of GIT. Here the esophagus is 14 millimeters in diameter, and because this is the narrowest portion of GIT, there are 2 points of significance. Number one, you know foreign bodies can get impacted here, which we will discuss in this module. And number two, because this is the narrowest portion, whenever we do endoscopy, the esophagus can get ruptured here. This is the most common site where a perforation, iatrogenic perforation, means endoscopy-induced perforation can happen, which also we'll discuss in the esophagus 2 module. So whenever endoscopy is done, all the distances are measured from the upper incisor. Upper incisor is taken as the reference point from which all the distances are measured. And I will show you a clip of endoscopy once I tell you about the anatomy, and you will see that there are 3 constrictions there. The first constriction is the pharyngo-esophageal junction. The first constriction is the pharyngo-esophageal junction, which is at 15 centimeters from the upper incisor. Then as we move down, the next constriction is when the arch of aorta or the left mainstem bronchus, they cross the esophagus. So the arch of aorta and the left mainstem bronchus, they will cross the esophagus. Now in anatomy, you would have been taught that these are 2 separate constrictions. But when we do endoscopy, arch of aorta and left mainstem bronchus is counted as a single constriction, and this is 25 centimeters from the upper incisor. So this is the arch of aorta and this is the bronchus, the left mainstem bronchus. When they cross the esophagus, that is the second constriction. And the third constriction is when the esophagus pierces the diaphragm. Right, when the esophagus pierces the diaphragm, and this is at the level of T10. So T10 is when it pierces the diaphragm, and that is the third constriction. This is 40 centimeters from the upper incisor. So you need to know these 3 constrictions, and you need to know the values at which these constrictions are there. I told you about the narrowest portion and the significance of the pharyngoesophageal junction. So let's watch a video of upper GI endoscopy. Now I've told you about the 3 constrictions, and in this upper GI endoscopy video you will see how the esophagus and the stomach looks like. So this is a video of normal upper GI endoscopy which I wanted to show to you so that you understand the problems later on. You can see, you've seen the larynx, the post-cricoid region, and now the gastroenterologist is entering the esophagus. So you can see the esophageal mucosa, and he's entered the esophagus, and as he goes down gradually, now you will see a change in the mucosal lining, and that is the GE junction, and now we've entered the stomach. After the stomach, you look above, so you can do a J maneuver, and you can see at the fundus, and then you enter into the duodenum. You can see here we've entered into the duodenum. This is D1 and D2. And after inspecting till D2, that is when we are going to start coming out. We will remove our probe and we'll come out after doing an upper GI endoscopy. Now, in anatomy, you would have been taught about the diaphragmatic openings, right? And there is a simple mnemonic which I remembered when I was preparing for my USMLE exams about diaphragmatic openings, and I would like to share it with you. That is I8, 10x at 12. Now, at the level of T8, you have IVC and the phrenic nerve which pierce the diaphragm. At the level of T10, you have esophagus, vagus, and left gastric artery which pierce the diaphragm. And at T12, you have aorta and thoracic duct when they pierce the diaphragm. So this is a simple way of remembering the diaphragmatic openings. We've discussed the relevant anatomy. Now we move on to the blood supply of the esophagus. Now the blood supply of the esophagus, I want you to know, is segmental in nature. So means each segment, upper 1/3, middle 1/3, lower 1/3 has a different blood supply. So upper 1/3 are supplied by the inferior thyroid arteries and the inferior thyroid veins. The drainage is by inferior thyroid veins. Middle 1/3 is by the descending thoracic aorta and the bronchial artery, whereas the drainage is into the azygous vein. The lower 1/3 is supplied by the left gastric artery. I told you, left gastric artery is piercing the diaphragm and it is supplying the esophagus, the lower end of esophagus as well. And the significance of this I will cover in the upper GI hemorrhage module, that there is a condition known as Mallory-Weiss tear. Now, Mallory-Weiss tear is a tear in the lower end of the esophagus, which
अपर वंथर किससे होता है? इंफीरियर थायराइड आर्टरी से। इंफीरियर थायराइड आर्टरी, अपर वंथर इंफीरियर थायराइड आर्टरी, अपर वंथर आर्टरी, इंफीरियर थायराइड आर्टरी, और ये इंफीरियर थायराइड वेन, इंफीरियर थायराइड वेन। मिडल वन थर्ड में डिसेंडिंग थोरेसिक अयोर्टा एंड ब्रोंकियल आर्टरी। इसोफेगस का मिडल वन थर्ड किस होता है? डिसेंडिंग थोरेसिक अयोर्टा, डिसेंडिंग थोरेसिक अयोर्टा एंड ब्रोंकियल आर्टरी। डिसेंडिंग थोरेसिक अयोर्टा मिडल वन थर्ड किस होता है? डिसेंडिंग थोरेसिक अयोर्टा से और ब्रोंकियल आर्टरी से। अजायगस वीन, मिडल वन थर्ड डिसेंडिंग थोरेसिक आर्टरी एंड अजायगस वीन। ठीक है, ऊपर वाला इंफीरियर थायराइड आर्टरी, लोअर वाला लेफ्ट गैस्ट्रिक आर्टरी, वीन में लेफ्ट गैस्ट्रिक वीन।
gives rise to upper GI hemorrhage. And this upper GI hemorrhage would be due to which artery? The left gastric artery. This question has been asked. I will again talk about this when I talk about upper GI hemorrhage in a separate module. Left gastric vein is what drains the lower end of the esophagus, and there are 2 points of significance which you should take from here. Number one is that this left gastric vein will join the portal circulation. This is going to join the portal circulation. So when it joins the portal circulation, this is going to be the site from which liver mets can occur from esophageal cancers. So esophageal cancers can spread along the left gastric vein, go into the portal circulation, and liver metastasis can be seen. And the other significance of the left gastric vein is that this can be the site of portosystemic shunts. Portosystemic shunts occur when there is portal hypertension. Portal hypertension, again, I've covered in upper GI hemorrhage module. In portal hypertension, vascular channels open up and there is shunting between the portal and the systemic veins. And this will give rise to varices, esophageal varices, which can bleed and they can give rise to upper GI hemorrhage. So we've discussed about the blood supply, the lymphatics. You should know that esophagus lacks serosa. Esophagus lacks serosa layer, and the strongest layer of the esophagus is submucosa. And the lymphatics which are there, they lie in the submucosal plane. And there is a longitudinal spread. There is a longitudinal spread of lymphatics, means that
esophagus lacks serosa. esophagus में serosa नहीं होता, ठीक है। और esophagus की स्ट्रॉन्गेस्ट लेयर कौन सी है? सबम्यूकोसा। लॉन्गिट्यूडनली स्प्रेड होता है। लिम्फेटिक्स जो होता है उसमें लॉन्गिट्यूडनल स्प्रेड होता है।
upwards, right? Longitudinal spread of lymphatics upwards and downwards they travel. So because of this longitudinal spread, there can be skip metastasis in cancer, and that is why we take a long proximal margin while doing esophagectomy. And this long proximal margin is 10 centimeter margin. Now you might be surprised to hear that, because if you remember in breast I told you 1 millimeter, in oral cavity 0.5 centimeters. Right? For penile cancer, 0.5 centimeters. We were taking such small margins, but here we are taking 10 centimeters, and the reason for that is because of this longitudinal spread of lymphatics. If I don't take such a long margin, then there can be recurrences. There will be a high recurrence rate, which is why we take a long proximal margin. And I will reiterate this when we talk about esophageal cancer. Esophageal sphincters are of 2 types. This is also relevant surgical anatomy because a lot of pathological conditions are related to these sphincters. Now, upper esophageal and lower esophageal sphincters, there can be 2 sphincters. The upper esophageal sphincter is both an anatomical and a physiological entity. What does this mean? This means that anatomical entity or anatomical sphincter is any sphincter which is an actual site of narrowing, where there is a narrowed passage. That is an anatomical sphincter. Whereas a physiological sphincter is when there is high pressure in that area. So in the upper esophageal sphincter, there are both. There is narrowing and there is high pressure. So it is both an anatomical and a physiological entity, and this is formed by the 2 parts of the inferior constrictor muscle, the thyropharyngeus and the cricopharyngeus. So
upper वाला both anatomical and physiological. फिजियोलॉजिकल लोअर वाला ठीक है.
sphincter is formed by the two parts of the inferior constrictor muscle, thyropharyngeus and cricopharyngeus, and thyropharyngeus has oblique fibers. Thyropharyngeus has oblique fibers, whereas cricopharyngeus has horizontal fibers. This is this has horizontal fibers. And you can see that there is a potential space between the fibers of thyropharyngeus and cricopharyngeus, and this potential space is known as Killian's dehiscence. This is known as Killian's dehiscence, and this is the site from which a Zenker's diverticum. This is Killian's dehiscence, and what can come out through Killian's dehiscence? Zenker's diverticulum, which I've come.
Thyropharyngeus oblique fibers. Cricopharyngeal horizontal fibers.
Esophagus, the patient can have dysphagia. Patient can have difficulty in swallowing. He would say that something is stuck, right? He will have a feeling that something is stuck in the food passage. Now, whenever you get a child, or for that matter an adult, I've seen adults who've swallowed their dentures and they don't get to know about it. So they will come to you. The first thing which you are going to do is you will do an X-ray in these patients, right? If it is not an emergency situation, sometimes the patient comes with choking, and in ENT and pediatrics you've been taught about Heimlich's maneuver to dislodge the foreign body. But if once they're stable, you are going to get an X-ray done for these patients. Now, when we get the X-ray done, what do we see? This is the appearance which we are going to get. Now, I want you to understand how the coin looks differently in the trachea or the larynx versus the esophagus, because in the last 2-3 years, lots of questions have been asked regarding foreign body of the esophagus. Now, for this, I will just make a demonstration, and that would make things clear to you. So look here, this is the respiratory passage, this is the larynx, fine. Now larynx, you can see that the antero-posterior diameter, this is the antero-posterior diameter is longer as compared to the side-to-side diameter, okay, side-to-side diameter. So what is going to happen, if the coin goes in the respiratory passage, it cannot lodge like this because the diameter is not that much. So this coin is going to lodge like this, fine. So when you take an AP X-ray, you will get a side-on picture of the coin. But if you take the lateral X-ray, you will see the end face. You will
इंटीरियर साइड से देखेंगे तो इंटीरियर साइड से देखेंगे तो कॉइन ऐसे दिखेगा, इंटीरियर साइड से देखेंगे तो कॉइन ऐसे दिखेगा, ठीक है। लेटरल से देखेंगे तो ऐसे दिखेगा, ये लेटरल इंटीरियर है, ठीक है।
See the entire coin, you can see the number, okay? So that is what happens in the larynx or the trachea. I want you to understand here that if we do the AP X-ray here, you can see the side view. I explained to you why. But if you do the lateral X-ray, you will see the end face of the coin. Fine? And one more thing which can differentiate is that esophagus is posterior, trachea is anterior, esophagus is posterior. So you can even see that you can see the respiratory passage here, right? You can see the gas shadow and the coin is lodged in the respiratory tract. So a lateral X-ray and the orientation of the coin can tell us whether the coin is in the esophagus or in the respiratory tract. Now, esophagus on the other hand is a tube, right? It's a tubular structure, I told you. And this tubular structure is collapsed. Normally it is collapsed, like I said. So if the coin is ingested, now the coin cannot go and lodge like this. Coin is now going to lodge in the esophagus like this. So if we do the AP X-ray in esophageal foreign bodies, you will see the end face. Now you can see here in the esophagus, you can see the end face on the AP view. Whereas on the lateral view, you can just see the side of the coin, right? In the lateral view, you can see the side of the coin. So I hope with this demonstration, it is abundantly clear to you of how we can diagnose whether the coin is in the esophagus or the trachea or the larynx based on the X-rays. Now, once we've done this, how do we manage esophageal foreign bodies? How do we manage esophageal foreign bodies? So, what did I tell you? The narrowest portion. Remember, the narrowest portion was C6. C6 was the narrowest portion. So, if the foreign body is lodged, if it is impacted at C6 and the patient is symptomatic, then we have to do endoscopic removal, right? We have to put in an endoscope and we have to remove the foreign body. But if it goes beyond C6, right, and the patient is asymptomatic, so you do the X-ray, you see it has gone beyond C6, patient is asymptomatic, you just keep the patient under observation. You tell the patient, you drink liquids, eat your normal food, and the coin would ultimately go down because it has traversed the narrowest portion of GIT. If it is stuck at narrowest portion, you need to remove it. Now, one exception to this rule is
impacted at C6. beyond an asymptomatic to observation.
Button batteries, and these have been asked in recent year exams as well, that children can sometimes swallow these button batteries, and button batteries need to be removed by endoscopy. Endoscopic removal needs to be done because they can undergo corrosion. They can corrode, and when they corrode, they can cause a perforation. The chemicals inside them can cause a perforation, which is why we should not leave button batteries even if they've gone beyond C6. If you can get them out by endoscopy, you should get them out. Okay. So this was the management of foreign bodies. The X-ray is very important. I've told you how the coins are oriented differently. The next is corrosive injury of the esophagus. And I never forget this topic because I had a junior of mine. He was 1 year junior to me at Safdarjung, and his brother was a foreign medical graduate in Russia at that time. And he must have been in his third or fourth year, and he'd gone to party with his friends in a bar in Russia. And there was a shot glass which was kept on the bar counter. Now he thought that there was alcohol in the shot glass, and he just picked it up and took the shot. Actually, the bartender had kept acid in that shot glass to clean the bar counter. And unfortunately, as soon as he drank that, the entire esophagus got affected by corrosive injury, and it was so bad that he had to ultimately come back to India, and he had to undergo an esophagectomy because of the extensive stricture which was there. So corrosive injury can either be due to alkali intake or it can be due to acid. So it could be alkali or acid. Now alkali injuries due to saponification by the alkali, they penetrate deeper. They are going to penetrate deeper, and they are going to cause more damage. That is why alkali injuries are more dangerous, because they penetrate deeper. On the other hand, acid injuries cause coagulation of proteins. They cause coagulation of proteins, and they don't penetrate deep. They don't penetrate deep as compared to alkalis. But one problem with acid is that they can cause pylorospasm in the stomach. They can cause spasm of the pylorus, which is the exit channel, and when they cause spasm of the pylorus, they can cause more gastric damage. So this you need to remember. Now, whenever you encounter a patient with acid or alkali injuries, sometimes you see a lot of, because of breakups or because of depression, suicidal tendencies, some people come, they drink acid or alkali, and they will come to the emergency. Now, whenever they come to the emergency, the first thing which we need to do is, because of breakups or because of depression, suicidal tendencies, some people come, they drink acid or alkali, and they will come to the emergency. Now, whenever they come to the emergency, the first thing which we need to do is, we need to give IV fluids to these patients. Now, there is a tendency that if they've had acid or alkali, to put in a nasogastric tube to do a gastric lavage. But blind insertion of these nasogastric tubes can give rise to perforation. So, NG tube should not be inserted blindly, can cause perforation, so we need to be careful. We need to be careful in these patients. It has been seen that there is no use of prophylactic antibiotics. This has been asked in the exam. And the most important intervention, this was a NEET PG exam question 4 years back, the most important intervention is an early skilled endoscopy within 48.
IV fluids, the nasogastric tube should not work. Should not be inserted blindly. Cause perforation. IV fluids cause perforation.
hours, right? After 48 hours, if this endoscopy is done, it will increase the risk of perforation. That is why it should be done within 48 hours. This helps you to delineate the extent of injury and to take necessary corrective measures. Okay? So this is the most important intervention. Please remember there is no role of steroid. This also has been asked in the exam. The definitive management for esophageal corrosive injury is the management of the stricture. Usually when it heals, it forms a stricture, or if there is a perforation, we need to carry out emergency surgery to address that. I have covered esophageal perforations later on in separate modules of esophagus, and you can see the detailed management of how esophageal perforation is managed there. But in most of the cases, the patient is going to land up with a stricture like this, and to manage the stricture, you can see the esophagus is strictured here. Here you can see the esophagus is dilated, right? Contrast can be seen, but the stricture starts from here. Can you see? This is all the strictured or the narrowed portion. So this is the extensive stricture. Now stricture we can either manage by dilatation. Or in extensive cases, an esophagectomy is required, like I told you in the case of my junior's brother. So this is the management of corrosive injury, and in the latest edition of Bailey, they've added a classification, or in extensive cases, an esophagectomy is required, like I told you in the case of my junior's brother. So this is the management of corrosive injury, and in the latest edition of Bailey, they've added a classification to classify the extent of corrosive injury. This classification is known as the Zargar's classification. This is the Zargar's classification, and it is based on endoscopic findings. It has not been asked, the details have not been asked in any of the exams till now. You should definitely remember the name. If you can remember the details, well and good. Otherwise, it has not been asked in any exam till now. 0 is normal, 1 is superficial edema or erythema, 2 is submucosal ulceration or mucosal ulceration, 3 is transmural ulceration with necrosis, and 4 is a perforation. So not very difficult to remember. This takes care of corrosive injury. The next condition which we need to discuss is a congenital problem that is known as congenital tracheoesophageal fistulae and esophageal strictures and atresia. So tracheoesophageal fistulae are of various types. You should know the types. They've also been asked in the exam. Type A is when the esophagus is blind ending. You can see esophagus is blind ending, and the two ends of the esophagus are not connected with each other. So this is known as esophageal atresia, where the two ends are not communicating but there is no fistula. This is type A. Type B is when the proximal end of the esophagus forms a fistula with the trachea. So proximal end forms a fistula with the trachea, but the distal end is blind ending. Distal end is blind ending in these patients. This is type B. Type C is when the proximal end of the esophagus is blind ending, not communicating, proximal end, but the distal end communicates with the trachea and forms a fistula. This is type C, and type C is the most common type of tracheoesophageal fistula. This has been asked many times. Type D is when both the ends are communicating with the trachea, and type E is when the esophagus is patent. You can see the esophagus is patent, but it has a fistulous connection with the trachea. This type, and type F is when there is just esophageal stenosis without a fistula. So these are the various types of tracheoesophageal fistulae which are there. Now you need to know that these tracheoesophageal fistulae are associated with NMYC gene mutation, And these tracheoesophageal fistulae, the mothers who are carrying these children can have polyhydramnios. They can have excessive amniotic fluid, and now this tracheoesophageal fistula can be detected on prenatal scans. They can be detected on prenatal scans. These tracheoesophageal fistulae can be detected. Now, supposing they are not picked up on prenatal scans, in government hospitals, you see a lot of these ladies coming in from villages. They've not had their antenatal checkups, they've not had ultrasounds, and they just come for their delivery. So, once the child is going to be born, this child is going to have excessive salivation, excessive drooling of saliva. There is going to be excessive drooling of saliva, means saliva is going to keep on coming out, and they can have respiratory distress as well. They can have respiratory distress. Now, I'm sure as interns, all of you must have taken deliveries or seen deliveries from both sides, from the gynecologist side and the pediatrician side. Now, whenever the child is born, the pediatrician, the first thing which the pediatrician does is they wrap the child, they clean the child, they suction the oral cavity, and they see for the anal opening, right? That is what they do. Now, this child will keep on having more and more secretions, and respiratory distress is also going to be there. So when there are excessive secretions which occur, what does the pediatrician do? The pediatrician tries to insert an orogastric tube. In these patients, okay? So they try to put in a tube inside the stomach so that all these secretions can come out. But which one is the most common? Type C. So type C, proximal end is blind ending and the distal end is communicating with the trachea. Now, in this patient, what is going to happen? That when the pediatrician tries to put in this orogastric tube, this orogastric tube will get coiled up. It is not going to go inside the stomach. So, there is going to be coiling of tube. So, this is another indicator that this patient might be having a tracheoesophageal fistula. So, excessive drooling, then you have respiratory distress, and coiling of this tube then points towards a tracheoesophageal fistula. So once we are suspecting tracheoesophageal fistulas, we have to confirm the diagnosis. And to confirm the diagnosis, we are going to do a contrast study. So the confirmatory test is a contrast study which is done. So basically, you are going to put contrast through the oral cavity, and that will delineate what is the anatomy of the tracheoesophageal fistula. Now, amongst the contrast, iohexol is better than dinosil. This was asked almost 5 years back in the NEET PG exam, that which contrast material is better. It is iohexol which is better than dinosil. So when we do this contrast study, let's look at this picture. Okay, so what was done was we were suspecting a tracheoesophageal fistula and the dye was given through the oral cavity. Now you can see the dye in the esophagus. This is the dye in the esophagus, right? This is the dye in the esophagus which is going down. So this represents the dye is coming right down till the stomach also. So this represents that the esophagus is patent. But you can see that there is a fistulous communication. You can see that there is a fistulous communication here. This is the other end of the esophagus. Okay, and this is the fistula. It is forming with the trachea. Right? You can see that dye is also coming in the trachea and the respiratory passage. So what kind of anatomy is this going to be? This is the H type, where the esophagus is patent, but there is a fistulous communication with the trachea. So this contrast study delineates the anatomy of the fistula. Now for H type, although I showed you the contrast study for H type, but if you are asked what is the investigation for H type, it is combined tracheoesophagoscopy. It is combined tracheoesophagoscopy. Okay. Now X-ray also delineates some important points to us. In X-ray, if stomach gas is seen, then stomach gas can come in two ways. Either the esophagus is patent, or the distal end of the esophagus, which is communicating with the stomach, distal end has a fistula with the trachea, and gas is coming from the trachea into the distal end into the stomach. Now, one thing which you should always remember, that if any child is diagnosed with one congenital anomaly, we should always rule out other congenital anomalies. And this has been taught to you abundantly in pediatrics as well. And the other congenital anomalies which you should rule out are Bacterel. This is a very common mnemonic which you would have seen at multiple places. We rule out vertebral defects, we rule out anorectal malformations, cardiac defects, which are the most common. TE is for tracheoesophageal, R is for renal, and L is for limb abnormalities. So these other abnormalities also we need to rule out in these children. So once we've done this, we come to the management of these children with tracheoesophageal fistulae. Now the management of these patients, there is a Watterson's criteria which is used to stratify this patient and to manage these patients accordingly. Now the Watterson's criteria takes into account two things. It takes into account the birth weight, and it takes into account whether pneumonia is present or not in these patients. Why would pneumonia be present? Because of a fistulous communication. The food particles or milk can sometimes go into the trachea, and that can give rise to pneumonia as well. Now, if the birth weight of the child is more than 2.5 kgs and pneumonia is absent, then these patients are good candidates for upfront surgery, right? For upfront surgical management of the tracheoesophageal fistula. But if the birth weight is 1.8 to 2.5 kgs, pneumonia is plus minus. Of course, in these patients, you will give antibiotics, build some weight by giving nutrition, and then we will operate. Right? So optimize these patients. Build the weight, treat the pneumonia, then you operate. But if it is less than 1.8 kgs, if the birth weight is very less and pneumonia is present or absent, in these patients what we do is that this was the tracheoesophageal fistula, the proximal end was supposing forming a fistulous connection. So what we do in these patients is that we will carry out a gastrostomy. Gastrostomy I've covered in the nutrition module. Gastrostomy is when you put a tube inside the stomach for nutrition. So we put in a tube inside the stomach, that is called gastrostomy. This is for nutrition. Why am I doing nutrition? Because in this patient I want to increase the weight, treat the pneumonia, and in these children we will do a delayed surgery once we see that the patient has started improving, the weight has started improving. Otherwise, the mortality is going to be very high in these children. So this was just a broad indicator of how we manage these children. What has been asked is the name Watterson's criteria. The details have not been asked in the last 6 years. I don't remember a single question regarding the details of Watterson's criteria. So you should just remember that birth weight and pneumonia are the two factors which are included in Watterson's criteria. Now, what is the actual surgical management of tracheoesophageal fistulae? So the surgical management of tracheoesophageal fistulae, you can have type A. Type A is atresia. Atresia means the two ends are not communicating with each other, but there is no fistula. Now there can be two outcomes here. One outcome is that the two ends are close to each other. Two ends are close to each other. So if the two ends are close to each other, it is common sense. What are we going to do? We are going to anastomose the two ends. We are going to join the two ends. But the other problem is that the two ends are far apart. Ends are far apart. So this I've covered so many times that if the ends are far apart, if they are very far apart, and if I try to join them forcibly, what is going to happen? You can very well imagine that if I pass a thread between these two papers and they are far apart, the thread will cut through the papers. Because of tension, it will cut through the papers. So that is why if the two ends are far apart, we cannot suture them immediately, right? We cannot suture them immediately. So if the two ends, one end is here, one end is here, what we do, I just told you. What we do is we will do a gastrostomy here. We are going to do a gastrostomy. We are going to put in a tube for nutrition, and as the child grows, the two ends are going to come close to each other. So when the two ends are sufficiently close, you will anastomose them. So we wait for the ends to come close to each other as the child grows, and then we anastomose. One more thing for these kind of patients is flourish device. Flourish device is a US FDA device in which magnets are put at both ends. In which magnets are put at both ends. So what will these magnets do? So if one end is here, one end is here, this is with the stomach, and if you put a magnet on both the ends, you know magnets are going to attract each other and they will hasten the growth. They will make the growth, or they will make them come close to each other faster as compared to if you just leave them. So this is how type A or atretic esophagus is managed. Now type B, C, D, E, where there is a fistula. Remember B, C, D, E, there was a fistula. So in these patients, we carry out what is known as Cameron-Hyatt surgery. Now what is Cameron-Hyatt surgery? Sounds like a very difficult name, but it is a simple concept. Cameron-Hyatt surgery is that this was my respiratory passage. This was the respiratory passage, and this was my fistulous communication with the trachea. Okay, so first of all, I need to expose this area. So to expose this area, I need to do a posterolateral thoracotomy. I need to do a posterolateral thoracotomy. Thoracotomy means opening up the thorax, right? I open up the thorax. And if you remember the general surgery modules, for thoracotomy, we were preferring the lateral position. So I'm going to open up the thorax. And why posterolateral? Because I know esophagus is posterior, okay? So with this, I'm going to identify the fistulous area, right? So I identify the fistulous area. Once I've identified the fistulous area, I am going to take down this fistula. I'm going to cut the fistulous connection, right? So the first thing is I have cut the connection. I cut fistula. Now once I've cut the fistula, then I have to repair the trachea. I have to repair the trachea, and if you remember the module on sutures, I told you take trachea and respiratory passages are repaired using PDS. PDS is polydiaxone, which is an absorbable suture, right, which gets absorbed in 180 days. So PDS, we repair the trachea. The next thing is we are going to anastomose the two ends of the esophagus. Right, so we take down the fistula, we repair the trachea, and now I'm going to anastomose these two ends. That is point number 3. So this is what is Cameron-Hyatt surgery, and then before closing, we put in a chest tube. So this is Cameron-Hyatt surgery, which is done for B, C, D, and type E. And this is the management of tracheoesophageal fistulae. I have told you the questions, I have told you the presentation, the workup, and the management of this condition. Next, we move on to a very, very important topic, that is GERD, gastroesophageal reflux disease. So this is gastroesophageal reflux disease. Now, I told you, normally, in most of us, the lower esophageal sphincter is in a state of tonic contraction. And because it is contracted, it does not allow the material from the stomach to come up into the esophagus or reflux up. So what are the factors which maintain the patency of the lower esophageal sphincter? So what are the factors which help in maintaining patency of lower esophageal sphincter and they prevent reflux? In other ways, these are the factors which are going to prevent reflux. So we know this is the lower end of the esophagus, this is the stomach, this is the diaphragm, right? This is the diaphragm, and I want you to know that the esophagus, there is certain portion of the esophagus which is intra-abdominal, which is intra-abdominal. So this is the intra-abdominal portion of the esophagus, and this intra-abdominal length of the esophagus is 3 to 5 centimeters. And this intra-abdominal length is the most important factor. This is the most important factor which helps in maintaining the patency of the lower esophageal sphincter. This you need to remember, because if there is adequate length of the intra-abdominal esophagus, this is the GE junction. This purple one is the GE junction. So if the intra-abdominal length is adequate, it will keep the GE junction intra-abdominal and it will prevent reflux. But if this length reduces, then this GE junction will open up and stomach acid will start coming up. So please remember this. This is the most important factor. Factor number two is the angle of his. So factor number 2 is the angle of his. Angle of his is the gastroesophageal angle. Angle of his is the GE angle. So most important factor was length of intra-abdominal esophagus. The second factor is the GE angle, gastroesophageal angle. The third factor is the pinching effect of the diaphragm. Right, the third is pinching effect of diaphragmatic crura. Pinching effect of diaphragmatic crura. This keeps the lower esophageal sphincter contracted. Right, so diaphragm will have a pinching effect. And the fourth factor is arrangement of mucosal folds. But this arrangement of mucosal folds has least contribution in maintaining the patency of the lower esophageal sphincter. So please remember, the most important factor is the length of the intra-abdominal esophagus. And if the length millimeters of mercury, this is when GERD will start occurring. And when GERD occurs, what is happening? Is the sphincter relaxing too frequently or it's not relaxing? Correct. It is relaxing too frequently. So in GERD, what happens? There is increased TLOSR. What is TLOSR? You will read this term. TLOSR is increase in the number of transient lower esophageal sphincter relaxations. Okay. So increase in the number of transient lower esophageal sphincter relaxation is a sign that GERD is occurring. So when you see people burping quite a lot, right, that is a transient lower esophageal sphincter relaxation. Now, these are some new points in the latest edition of Bailey, that increase in GERD has been attributed to an increase in obesity and declining rates of H. pylori. I want you to remember that H. pylori, which can cause gastritis, but it is preventive for GERD. Central obesity is a risk factor which is increasing GERD, and with GERD, Barrett's esophagus and cancer risk is also increased. This we will cover in some time. I will tell you about this in some time. Now, what are the clinical features of GERD? Now, GERD is so common that if you're an MBBS student or an intern, and if you're having your mess food in a government hospital or a private hospital as well, mess food is never good. It is so spicy, it is so oily that invariably you develop GERD. At least once you would have experienced these symptoms. The most common symptom is retrosternal burning sensation, also known as heartburn. It's not the heartburn when you get matched with the wrong person on a dating app. That's not the heartburn which I'm talking about. This is burning sensation behind the sternum. Then you can have water brash. Sometimes if you eat spicy food or if you get acid coming up, you get this such bitter taste in your oral cavity, right? And you feel like choking kind of a sensation, that is known as water brash. Then because of recurrent GERD, patients can have pharyngitis, laryngitis, their voice can change, they can have dental caries, they can get up at night or they get up in the morning and they have a bad taste, a bitter taste in the oral cavity. So all these features and chronic cough These are all the clinical features of GERD which you should know about. Now you need to understand that GERD is so common that if a patient with classical symptoms of GERD goes to any doctor or a gastroenterologist, they straight away will not do investigations, right? What they will do is that they will start the patient on empirical treatment for GERD. And only if the empirical treatment is not working or the symptoms are progressing, then only investigations would be done. Now, what are the investigations which are done? And there are 2 points. I want you to be crystal clear about these 2 points because they've been asked multiple times in the exam. Now, one is investigation of choice and the other one is gold standard investigation. And often students get confused between the two. The investigation of choice is an upper GI endoscopy. This endoscopy will show us that the lower end of the esophagus is inflamed because of acid reflux. So this is the investigation of choice. Whereas the gold standard investigation, and I've told you gold standard is one which will tell you the diagnosis 100% times, but it might not be the most feasible investigation to do, okay? So the gold standard investigation is 24-hour pH monitoring. Now this will give you the diagnosis 100% times, but we are only doing this if endoscopy is inconclusive, or if intervention is planned. If we know the patient has GERD and we are planning a surgery, then before the surgery we do a 24-hour pH monitoring, okay? Now 24-hour pH monitoring, the pH probe is kept 5 centimeters proximal to GE junction, okay? 5 centimeters proximal to GE junction, and in these patients we should stop PPIs. What is PPIs? Dr. Ranjan must have taught you proton pump inhibitor, right? This is one medicine which all doctors must have consumed at least once during their careers, and this is one medicine for which doctors are always chasing medical representatives for samples. So we stop PPIs 5 to 10 days before the procedure to get accurate results, because if you do the procedure on PPIs, then you will not get the representative findings. Now when this
भाई मेरे को मेरे स्पेक्स लाने पड़ेंगे. मेरे को ना ऐसे धुंधला धुंधला दिख रहा है. मैं बिना स्पेक्स के लेक्चर देख रही हूँ. मेरी आंखें ना एकदम ऐसे धुंधली धुंधली हो चुकी है. कुछ भी नहीं दिख रहा ढंग से. आइज पेन हो रही है, वो अलग. मैं स्पेक्स लगा के लेक्चर देखूंगी, मुझे बेटर फील होगा. भाई कौन है ये एक इंसान जो बार बार ज्वाइन होता है, बार बार लेफ्ट हो जाता है? हु इज़ दिस पर्सन? ये बीटी भीट, ये तो मेरा भाई है. बढ़िया बढ़िया, करो करो. ओ थैंक यू. अब अच्छे से पढ़ाई करूँगी. मेरा फ़ोन 11% बचा है और अभी तो मुझे 58 मिनट्स और पढ़ाई करनी है. 2 आवर का चैलेंज लिया था क्योंकि मैंने यहीं पे सही था क्या? कहाँ रखूँ? मेरा फ़ोन इतना गर्म क्यों हो रहा है? कोई बात नहीं, कोई बात नहीं. 1 घंटे की और बात है.
24-hour pH monitoring is done. We calculate the Demister score. The Demister score is calculated, and if the Demister score is more than 14.72, then this is indicative of GERD. Okay, it is indicative of GERD. So this is regarding the investigations which are done in these patients. Now, like I said, most of the time these patients are started on empirical treatment without any They are started on empirical treatment without any investigations. So whenever a patient comes with GERD, you tell them that there are certain lifestyle changes you need to make. Number one, the lifestyle changes. Lifestyle changes, you tell them to reduce weight. Why? Because I told you obesity is an independent risk factor for GERD. So if you are overweight, you will have more chances of GERD. And as the patient loses weight, GERD also reduces. I've seen this in many of my breast cancer patients. Okay, so weight reduction. Then very important is we tell them to avoid food items which relax the lower esophageal sphincter, because if the sphincter relaxes more, there'll be more GERD. So what are these food items? These food items are fried food, fatty food, citrus fruits, chocolates, mint, right? So fried, fatty, spicy food, chocolates, mint, all these things you have to tell the patient to avoid. So essentially everything what is available in your college canteen is out. So there is a very restricted number of items which these patients can eat. Then we tell them to take small frequent meals, because if they take a heavy meal, more chances of reflux happening. So we tell them to take small frequent meals, and we tell them that the dinner should be taken at least 2 to 3 hours, 2 to 3 hours prior to sleeping. So the reason of this is that when you lie down, there is more chances of reflux happening, which is why the meal should be taken at least 2 to 3 hours before the person goes off to sleep. Now sometimes the elders in your homes will tell you that if you're having reflux, put an extra pillow. And that was written in old textbooks. But the latest textbooks say that by adding one pillow, you are not reducing the incidence of GERD. So these are the lifestyle changes. In addition to this, medications can be given to these patients as well. The medications which can be given are proton pump inhibitors, prokinetic agents. Prokinetic agents can be given, and antacids can be given, right? Antacids can be given. So these are the medications which can be used in these patients as well. Now, some of these patients will not respond to the treatment. Majority will. Majority don't require surgery, but some of them will not respond to the treatment, or they will have complications, or they would want to stop the medications, and these would be the patients who would require surgery. So the indications for surgery are patient not responding to medical management, patients suffering from complications of GERD. Complications of GERD, we are going to talk about Barrett's esophagus, which is a very important complication. There can be a stricture which can develop. There can be adenocarcinoma which can develop, right? Adenocarcinoma which can develop. Some patients can have a hiatal hernia. Hiatal hernia I've covered in the other esophagus modules. A sliding hiatal hernia can be associated with GERD, and these patients will also not respond to medical management and would require surgery. And finally, you have a patient who's well controlled on medicines. So this patient was well controlled on PPIs, but somebody told him that long-term PPIs can give rise to cancer or can cause complications. So the patient now wants to leave his medicines. So if he leaves the medicines, the symptoms are going to come back. So the only way to control it is with surgery. So these are the indications when surgery has to be done in these patients. And the surgery which is done is known as fundoplication. So fundoplication is the surgery which we carry out. And what are the principles of fundoplication? I just demonstrate to you, and then I'll show you an operative video as well. So we know that the normal intra-abdominal length, I told you, was 3 to 5 centimeters for the esophagus. Now, if the intra-abdominal length reduces, means it becomes less than 2 centimeters, then GERD occurs. So the first point in fundoplication is to restore adequate intra-abdominal length. Minimum 3 centimeters length we need to restore here. Minimum 3 centimeters length we need to get here. Then we need to tighten the diaphragmatic crura so that the esophagus doesn't move up again. Then what we have to do is we take the fundus of the stomach. You know the stomach has a fundus. We take the fundus of the stomach, and we are going to wrap the fundus of the stomach. We are going to wrap the fundus of the stomach in front of the esophagus. Okay, around the esophagus. This is called fundoplication. And the way we wrap the fundus of the stomach, this maneuver is known as shoe shine maneuver. Okay. Now, honey, my daughter has started going to school, and we are teaching her how to shine her shoes, and we've given her a shoe brush, and this is how she shines in the morning. This is how we all used to do it when we were in school. So this is known as the shoe shine maneuver. Now we preserve the vagus nerve and we have to maintain the angle of his, because I told you the angle of his is also responsible for keeping the lower esophageal sphincter patent. Okay, so these are the principles. Let's see a short clip which demonstrates fundoplication, and then I'll tell you about the types of fundoplication. So this is a video of fundoplication, and this was shared by Dr. Pankaj, who is Dr. Sakshi's husband. He's a laparoscopic surgeon. So he had shared this video, and here you can see that first the liver retractor is being put into place so that we can get adequate exposure, and then we are going to start dissecting out the lower half or the abdominal part of the esophagus. So you can see here, this is the attachments are being freed, and we are going to expose the diaphragmatic opening and the lower part of the esophagus. So you can see the attachments are being freed up. So now the attachments are being freed up and we've reached the diaphragmatic hiatus. You can see the cardiac pulsations as well. So this is the diaphragm, and you can see how the diaphragmatic hiatus is being opened up. The lower part of the esophagus is being dissected so that then we can wrap the stomach around it, and we can also tighten the diaphragmatic hiatus again. So you can see the crurae of the diaphragmatic opening which are there, and the esophagus is being freed up. Okay. You can see that with laparoscopy you get a great amount of magnification, and that is one of the advantages of minimally invasive surgery, which I've also highlighted in the minimally invasive surgery module. So you can see here now the esophagus is very well dissected, and then once we have done that, the fundus is going to be mobilized and it is going to be taken all around the esophagus. It's going to be wrapped around the esophagus. So now you can see that the diaphragmatic hiatus is being tightened, and you can tighten this using proline suture, so that proline suture is in place, and the hiatal
Shit, मेरा phone 7% बचा है.
repaired, so that again the esophagus does not move up, and we know if the esophagus moves up, then there's going to be reflux.
50 minute बचा है.
And one of the main principles of fundoplication is that we have to bring down the esophagus. We have to recreate the intra-abdominal length of the esophagus. Right? We have to tighten the hiatal opening, and we have to wrap the fundus around the esophagus. Those are the key steps of fundoplication.
भाई इसको रख भी नहीं सकते, चार्ज भी नीचे लगता है ये. हद है.
There is a shoe shine maneuver, and that has been asked multiple times in the exam, that you should easily be able to mobilize the fundus around the esophagus, and this maneuver
Charging. इसको रखो कैसे?
is known as the shoe shine. So this you can see that the fundus is being wrapped around the esophagus. The hiatus has already been tightened, and this will then complete our fundoplication. And we know that we have to minimum achieve a length of 3 centimeters of intra-abdominal esophagus. That is what we want to achieve. Minimum 3 centimeters length of the intra-abdominal esophagus. So these are the fundoplication stitches which are being taken, and this is our complete fundoplication which has taken place now, and this is the completed repair at the end. Now the types of fundoplication, you can have complete wrap, that is Nissen's fundoplication, which is a 360-degree wrap. Now complete wrap is that completely you are wrapping the fundus of the stomach. Now sometimes this can be so tight that the most common complication which patients encounter after complete fundoplication is gas bloat syndrome. This has been asked many times in the exam. Gas bloat syndrome is that the fundus has been so tightly wrapped around the stomach that the patient cannot even burp now, right? Cannot even, the gas also cannot come up, cannot burp also. That is known as gas bloat syndrome. And because of this, partial wraps have now been started to be done, because they will have less chances of this gas bloat syndrome. So partial wrap door is 180-degree anterior wrap.
Lecture कहाँ चला गया?
Also, that is known as gas bloat syndrome. And because of this, partial wraps have now been started to be done, because they will have less chances of this gas bloat syndrome. So partial wrap door is 180-degree anterior wrap, toupee is 180 to 270-degree posterior wrap, and Belsay mark is 270-degree anterior wrap. Now this can be a bit confusing, so I just want you to remember Nissen's.
Types of fundoplication, complete wrap, Nissen 360-degree. अच्छा, टाइप्स ऑफ फंडोप्लिकेशन, कंप्लीट रैप करेंगे 360 डिग्री तो नीजन मोस्ट कॉमन कॉम्प्लिकेशन गैस ब्लड सिंड्रोम. पार्शियल रैप करेंगे 180 डिग्रीज इंटीरियर, टॉप पे 180 to 27 डिग्रीज पोस्टीरियर, बेल्सले मार्क में 270 डिग्रीज इंटीरियर.
Remember the names of the partial wraps, but there is no point remembering the angles because in the last 6 years, I have not seen a single question regarding the angles of partial wraps in any entrance exam. Now, fundoplication, like I showed you, is done in a laparoscopic manner. Nissen's was a 360-degree wrap, and toupee is a partial wrap, which I've just shown you. Now, Coley's gastroplasty is another surgery which can be done, and this is done when esophageal shortening is there. When esophageal shortening is there. So when there is esophageal shortening, I cannot get adequate intra-abdominal length. So with Coley's gastroplasty, I can create a neo-esophagus. I can create new esophagus out of the stomach, and this is by firing a linear stapler. Remember a linear stapler I've shown to you in the sutures module. So you fire a linear stapler along the greater curvature of the stomach, and this is going to create increased length of the esophagus. Neo-esophagus, Coley's gastroplasty is done. Now, in the latest Bailey, there are some newer modalities for the management of GERD as well, and I want you to know about this. So one of them is polymer injection around the lower esophageal sphincter so that it keeps it contracted, but this has a high recurrence rate and it is not preferred. Endoscopic radio frequency ablation, this is very important. This has good long-term results. RFA is radio frequency ablation. This I have covered in the module on cautery and blades. Radio frequency ablation has good results here. Link's device is magnetic sphincter augmentation. So you put magnets around the lower esophageal sphincter and they will keep the sphincter closed. And in the latest edition of Bailey, there is also a transoral incision-less fundoplication. So in laparoscopy, you have to make incisions from outside. But now there are procedures where they are doing a fundoplication from inside while doing endoscopy. And such a procedure is known as a NOTES procedure. NOTES stands for Natural Orifice Transluminal Endoscopic Surgery. Natural Orifice Transluminal Endoscopic Surgery. To know more details about NOTES, you should refer to the module on minimally invasive surgery. In minimally invasive surgery, I've told you about the types of NOTES procedure, so please refer to that module. So this takes care of GERD. We've discussed why it occurs, clinical features, management, investigations, and the surgeries. Now, one of the complications of GERD is Barrett's esophagus, which is extremely important from the point of view of the exam. Now, Barrett's esophagus is metaplasia. Metaplasia is conversion of one epithelium into the other epithelium, and this is also known as specialized intestinal metaplasia. So, Barrett's is also known as specialized intestinal metaplasia, and this is metaplasia of squamous epithelium to columnar epithelium. So the squamous epithelium gets converted into squamous epithelium in these patients. And the pathognomic findings, so in Barrett's esophagus, when you see the Barrett's, you get a red velvety mucosa, right? You will see this typical red velvety mucosa is what you're going to see. And the pathognomic finding, if you take a biopsy from this red velvety mucosa, is the presence of goblet cells. That is what is going to clinch the diagnosis in these patients. So if you see the histopathological slide, you will see goblet cells. Goblet cells are these mucin-producing cells. These are known as goblet cells, and they will be seen on the esophagus histopathology slide. So you are going to see goblet cells on biopsy. Now, what are the clinical features of Barrett's esophagus? So the clinical features of Barrett's esophagus are same as GERD. The patient will have same clinical features because this is a complication of GERD only. And these would be patients who don't respond to medicines, But Bailey also writes that a lot of GERD and Barrett's patients can have a silent presentation, right? That these patients can have a silent presentation and it is only detected when they are developing complications or cancer. And Barrett's esophagus increases the risk of adenocarcinoma of the esophagus. Not squamous, it increases the risk of adenocarcinoma of the esophagus. Now, there are three types of Barrett's esophagus. You can have short segment, long segment, and cardiometaplasia. Now, long segment is when the length of the Barrett's is more than 3 centimeters. Short segment is less than 3 centimeters. And cardiometaplasia is microscopic Barrett's. Now, if the Barrett's is very well visualized, if it was typical red velvety mucosa like this one, then I know where to take the biopsy from, right? And I will take multiple biopsies. So biopsies, I will tell you later on in the module that they are taken at every 2 centimeters to confirm Barrett's esophagus. So this would be taken from the affected area. But the problem is that you might have cardiometaplasia or microscopic Barrett's. Now this is Barrett's which will not be visualized by the naked eye. So in these patients, to identify abnormal mucosa, we carry out chromoendoscopy. We carry out chromoendoscopy. Chromoendoscopy is that we stain the esophagus with a particular dye, and this dye will then highlight to us what is the abnormal area. Now, I'm sure in gynecology, you must have read from Dr. Sakshii that even in the cervix, if you want to find out the abnormal areas, you stain the cervix with acetic acid, and it will give you the aceto-white areas, which are the abnormal areas, which you can then biopsy. So similarly, to identify abnormal areas, we can stain the esophagus with Lugol's iodine, which can tell us about squamous epithelium. But for Barrett's and for adenocarcinoma, we use methylene blue. So by staining the esophagus with methylene blue, I will get to know what are the abnormal areas, and then I can take a biopsy from those abnormal areas. So that is how we confirm the diagnosis of Barrett's esophagus. Now, in Barrett's esophagus, there is another update which I want you to know. This is there in the latest edition of Bailey. This is known as the Prague C and M criteria. Prague C and M criteria. So this tells us that we first have to identify the GE junction. Okay, we identify the GE junction during endoscopy. And once the gastroenterologist has identified the GE junction, then they will measure the distance from the GE junction to the maximum point where Barrett's is extending. That is the M value, maximum value from the GE junction. And then they will also see what is the point till there is circumferential involvement of Barrett's. Means Barrett's is involving 360 degrees. That is the C value, circumferential extent. So the significance of this Prague C and M criteria is that higher the C and higher the M values, it denotes that there is more extensive Barrett's and more risk of malignant conversion can be there in these patients. Now, in Barrett's, there is only metaplasia, but if metaplasia, you read in pathology that if metaplasia is left for a long duration, it can turn into dysplasia, and dysplasia can turn into invasive cancer. So the risk of cancer increases with metaplasia to dysplasia to in situ cancer. Now, how do we manage these patients? These patients are managed using the Seattle protocol. So this is the latest Seattle protocol to manage Barrett's esophagus. Now, in Seattle protocol, it is given in great detail in Bailey. I don't want you to get confused. This is the flowchart given. I'm going to simplify it for you. Right? So, first thing is that if there is no dysplasia, okay, if there is no dysplasia means there is only metaplasia. There is only metaplasia. So if there is no dysplasia, then we repeat endoscopy and biopsy every 3 to 5 years. 3 to 5 years. That's all you need to remember here. You don't need to remember these details. So if there's no dysplasia, if you do a biopsy and only Barrett's comes, only metaplasia comes, you repeat the endoscopy every 3 to 5 years and take biopsies. Now, if dysplasia comes, right? If there is dysplasia, LGD is low grade dysplasia. So first of all, you need to remember that this dysplasia needs to be confirmed by 2 pathologists. So if there is dysplasia now, you know that there is a higher risk of conversion into cancer. So to reduce that risk, we have to carry out ablation of the mucosa. We have to ablate abnormal mucosa. Ablate means we have to destroy that abnormal mucosa. How do we destroy that abnormal mucosa? We use radiofrequency ablation. So this Seattle biopsy protocol, I have told you that we will do 4 quadrant biopsies every 2 centimeters, and we will do targeted biopsies of visible lesions. That is how we are going to monitor Barrett's esophagus. RFA, radiofrequency ablation, is the most popular way of ablating abnormal mucosa. It is cost effective and the side effective profile is also better for these patients. EMR can be done. EMR is endoscopic mucosal resection. Endoscopic mucosal resection or multiband technique can be done to remove the whole mucosa, but this EMR technique has high rate of stricture. Endoscopic ablation can be done in flat lesions. So please remember that RFA is the best modality to ablate this abnormal mucosa. So let's come back to this table. Now, if there is low-grade dysplasia, you are going to ablate the mucosa using RFA. Now, because there was dysplasia, Will you do endoscopies every 3 to 5 years, or would you like to do them at a more frequent interval to see if any change is occurring or not? Of course, you would do them more frequently, right? You want to see if there's any change occurring. So that is why 6 monthly endoscopies are done. 6 monthly endoscopies are done till two negative biopsy results come. Means two biopsy results show that there is no longer any dysplasia. Till then you keep on doing 6 monthly endoscopies, and then you shift to 3 to 5 yearly. Now, if there is high grade dysplasia, or there is cancer, then again, ablate the abnormal mucosa. You discuss in the MDT. MDT stands for multidisciplinary team meeting. You discuss with the surgeon, with the gastroenterologist, with the oncologist, and you now take a plan for surgery. What surgery will you do? Esophagectomy. Right, so to summarize for everyone, no dysplasia, continue 3 to 5 yearly biopsies and endoscopy. Dysplasia, low grade, ablate the mucosa, keep on doing 6 monthly endoscopies till you get 2 negative results, means 2 consecutive biopsies show that there is no dysplasia.
भाई मेरा फ़ोन बहुत ज़्यादा हीट हो चुका है, मैं नहीं चाहती ये ख़राब होए। अभी भी 30 मिनट्स बचे हैं पढ़ाई को, पर ये डिस्चार्ज हो चुका है और इसको मुझे इसे टेढ़ा रखना पड़ रहा है। लाइक इट्स ऑफ नो यूज़। पता नहीं, मुझे समझ नहीं आ रहा मैं क्या करूँ। लाइव तो एंड में कर नहीं सकती, 2 घंटे पढ़ाई करनी है। सही दिख रहा है। बहुत ज़्यादा गर्म हो रहा है भाई मेरा फ़ोन।
Then you move to 3 to 5 years. If there is high grade dysplasia or T1 cancer, confirm, discuss in a MDT and do esophagectomy. That is how we manage Barrett's esophagus, and this is the Seattle protocol to manage Barrett's esophagus, where I've told you that biopsies were being done at every 2 centimeters. Now, all the topics which I have covered in this module are also been asked as short notes in your college exams, and multiple MCQs have been asked from all of them. So before I end this module, I want to discuss this very interesting image which I saw while reading a book, and it is so relevant for anything we do in life or any exam which we are preparing for. So for any exam, to crack any exam, you have a strategy. So a strategy is basically is going to be your broader picture which you will use to crack an exam. And to implement the strategy, you are going to use tactics, individual tactics to implement your strategy. Now, this graph shows that if there is no strategy, and no tactics, then you will just be in a maze. You will not know where to start and where to end. You will be lost. Okay, so you can't succeed without any strategy and tactics. Now, if there is no strategy but you have tactics with you, that would result in mindless activity. So you would keep on doing something and you would think that you are achieving something, but you would not go the distance. You will not hit the bigger picture. You will keep yourself busy. You will think you're doing something, but it is not going to yield results. If you have a strategy but you don't have tactics, then you will just be talking. You will be a good talker. You would say that my strategy is this is how I'm going to do it, this is what I'll do, but you would not be able to implement it, right? So you'll just be blowing a lot of hot air, but no results. So in order to achieve your target, you need to have a good strategy and you need to have good tactics, both. And most importantly, you need to have discipline to implement both of them and achieve your goals. So this is something which I wanted to share with you. Now, before we end, let's just quickly do a couple of questions. A baby playing unsupervised complains of difficulty in swallowing since the last few hours. X-ray is done. What is the diagnosis?
Coin.
So remember here,
body,
on the AP view, you can see the entire coin. And on the lateral view, you can see the side view. So this would be when the coin is in the esophagus or the trachea. Correct. It will be in the esophagus. Trachea would have been that on the lateral view, you would have seen the entire coin. Correct. Now, a 5-year-old child swallows a button battery, and on investigation, it has been found to be in the stomach. Patient is asymptomatic. What is to be done? Remember, I've discussed any button battery, even if it is in the stomach, you need to carry out endoscopic removal. We don't leave button batteries because these button batteries can corrode and cause perforation. Now, this is a very interesting question. All of the following patients are good candidates for fundoplication or anti-reflux surgery, except. So you have a 31-year-old male with typical GERD, and the disease is becoming resistant to medical therapy. So if the disease is not responding to medical therapy, you will do fundoplication. Yes, this patient is a good candidate because one of the indications I told you was not responding to medical management. Second is 55-year-old lady with disease well controlled on PPIs. But now she wants to stop PPIs. She doesn't want to take PPIs anymore. So when she stops PPIs, her symptoms are going to come back. So she will also benefit from surgery. 75-year-old male with new onset heartburn. He's 75, first time in his life he's having heartburn, and there is weight loss also, which is not relieved by PPIs. So do you think at 75 this is GERD or this is a symptom of something else? This represents cancer. There is weight loss, new onset heartburn, and this patient will not benefit. This will be the patient who will not benefit from anti-reflux surgery. 52-year-old man with volume reflux means large volume reflux, and I told you hiatal hernia. Hiatal hernias can be associated with it, and this patient will also benefit from fundoplication. So this brings us to the end of the first part of esophagus. Thank you.
मेरा एक लेक्चर पूरा हो चुका है और अभी भी मुझे 30 मिनट्स और पढ़ाई करनी है। मेरा एक लेक्चर पूरा हो चुका है पर अभी भी मुझे 29 मिनट्स और पढ़ाई करनी है और मेरा फ़ोन इतना ज़्यादा हीट हो चुका है, पर पढ़ाई तो करनी पड़ेगी। मैं नोट्स पढ़ लेती हूँ, ज़्यादा बेटर रहेगा मुझे। नोट्स मुझे लगता है मैं पहले क्वेश्चंस कर लेती हूँ, क्योंकि मुझे भी नहीं पता कि मैंने कितने कंसंट्रेशन से सुनी है, कितनी चीज़ें मेरे दिमाग के ऊपर गई है। तो मुझे लगता है कि अगर मैं क्वेश्चंस पहले करूँगी तो मेरे को थोड़ा कंसंट्रेशन और बेटर हो जाएगा, मुझे पता लगेगा कि मैंने क्या चीज़ ढंग से नहीं सुनी। पहले क्वेश्चंस कर लेती हूँ। इसके अकेले के क्वेश्चंस है ही नहीं, 3 लेक्चर्स के मिला के हैं। नोट्स ही पढ़ लेती हूँ। कंस्ट्रक्शंस यार, पंखा cognitive abilities. चेक करी, उस पर मेरे 11.1 के व्यूज़ हो गए। मतलब मेरी पहली रील है जो मतलब अभी तक मेरी कोई भी रील 10,000 तक भी टच नहीं किया मेरी किसी भी रील ने। और आज जो मैंने रील डाली है तो उस पर 11.1 के व्यूज़ हो गए। मतलब मुझे रहा नहीं जा रहा था, आई नो पढ़ाई का टाइम चल रहा है, पर मुझे बिल्कुल नहीं रहा जा रहा था। मैंने सोचा कि एक बार व्यूज़ चेक कर लेती हूँ, तो मतलब मेरे को खुशी हो रही है। छोटी बात होगी पर मेरे लिए नहीं है, क्योंकि मेरे कभी भी इतने भी नहीं आए। तो ये पहली बार मेरी किसी रील पे 11.1 के व्यूज़ हुए हैं इंस्टाग्राम पे। यूट्यूब पे कभी नहीं हुआ है। यूट्यूब का मैं भी देख भी नहीं सकती, क्योंकि मैं लाइव हूँ, मैं इसे क्रॉस नहीं कर सकती। पर मैं खुश हूँ। भाई 8:30 हो चुके हैं, मुझे डिनर करने भी जाना है। डिनर भी चला जाता है। 9 मिनट और 2 घंटे का नाम लिया है तो 2 घंटे मैं पढ़ाई करने वाली हूँ। 2 घंटे से पहले मैं नहीं उठूँगी, भले ही मुझे कुछ बना के खाना पड़े। मेरे 2 घंटे पूरे हो चुके हैं पढ़ाई के, और मैंने एक इसोफेगस का लेक्चर देख लिया, उसके नोट्स पढ़ लिए, और मैं क्वेश्चन नहीं कर पाई क्योंकि क्वेश्चन ना 3 लेक्चर्स के साथ में थे, तो मैं वो बाकी के 2 लेक्चर देखूँगी, उसके बाद ही क्वेश्चन सॉल्व कर पाऊँगी। तो बट चलो कुछ तो पढ़ा, क्योंकि मैं घर से वापस आई हूँ ना, तो घर से वापस आने के बाद मेरा बिल्कुल मन ही नहीं कर रहा पढ़ने का, तो मुझे लगा कि ये तरीका बेटर है। मैं ना लाइव जाती हूँ यूट्यूब पे, मुझे पता है मेरे को सब्सक्राइबर तो अभी तक है नहीं, कोई देखेगा भी नहीं, पर एक मेरे में अंदर से डिसिप्लिन वाली चीज़ आ जाएगी कि यार हाँ मैं लाइव हूँ, और मैंने लाइव की स्टार्टिंग में बोला है कि मुझे 2 घंटे पढ़ना है, तो मैं 2 घंटे से पहले नहीं उठूँगी। इस चक्कर में मेरी थोड़ी तो पढ़ाई हुई, मैं उतना प्रोडक्टिव नहीं रह पाई, बट हाँ बाकी डेज के कंपैरिजन में इट वाज सो गुड। और अब मैं सोच रही हूँ कि 21 डेज़ का चैलेंज स्टार्ट करूँ। मैं 21 डेज़ के लिए डेली लाइव जाऊँगी और डेली 2 घंटे पढ़ाई करूँगी। टाइम इज़ नॉट फिक्स्ड येट, आगे मैं फ़िक्स कर दूँगी टाइम भी, बट अभी तक मुझे नहीं पता है किस टाइम पढ़ने वाली हूँ। पर हाँ 2 घंटे, या फिर अगर मुझे सही लगा तो 3 घंटे भी, क्योंकि मेरे 1 महीने बाद इंटरनल्स आ रहे हैं, तो मुझे पढ़ाई तो वैसे भी करनी है, तो ये काम भी हो जाएगा, वो भी हो जाएगा, और ऐसे तो मैं पढ़ूँगी भी नहीं। अगर मैं यूट्यूब पे लाइव जाऊँगी तो मैं इस चक्कर में पढ़ाई तो करूँगी। आज मैंने एक 80 मिनट्स का लेक्चर कंप्लीट कर लिया, नोट्स कंप्लीट कर लिए उसके, कुछ तो गया मेरे दिमाग में। तो मैं खुश हूँ, ठीक है। एंड अभी मैं इसको लाइव को यहीं पे एंड कर रही हूँ। टाइम हो चुका है, केवल 1 मिनट बाकी है, तो बस 1 मिनट ही बाकी है, हो गया मेरा 2 घंटे का स्टडी सेशन कंप्लीट। थैंक यू गाइस, जो भी 16-17 लोग थे जिन्होंने भी ज्वाइन किया, थैंक यू सो मच। अब मैं डिनर करने जा रही हूँ, क्योंकि थोड़ी देर में डिनर ख़त्म हो जाएगा, मुझे कुछ भी नहीं मिलेगा। मेरी फ्रेंड पारुल मुझे 2 बार कॉल कर चुकी है। हाँ, और मैं वैसे भी खुश हूँ क्योंकि मेरी रील पे 11K व्यूज़ हो गए। अब नहीं, अभी मैंने जस्ट देखा 11.5K हो गए, तो मतलब पहली बार कोई रील मेरी 10K से ऊपर गई है। 10K भी टच नहीं होता था, पहली बार टच हुआ है, तो मैं खुश हूँ। अब मैं इसको 27 आई शो यू कि वो कौन सी रील थी। ये वाली रील थी। ओ वाओ 11.6K, वाओ। मुझे आज का व्लॉग भी डालना है। ये गुड, वेरी गुड साक्षी, वेरी गुड। तो बाय, थैंक यू फॉर वॉचिंग, फॉर ज्वाइनिंग, बाय।